I'm Dr. Lora Shahine. Welcome to my YouTube channel. Today we're going to talk about 5 things you should know about lesbian family building. I'm Dr. Lora Shahine. I'm a reproductive endocrinologist helping people build their families for over 15 years. And I love helping building all types of families. I appreciate all your questions about lesbian family building. And this video is a part of a series all about it. When you have 2 people with 2 uteruses and usually about 4 ovaries, there's many options for family building, and it's easy to get confused. And if you're just getting started, I hope that these videos are helpful. So I have another one kind of on getting started and another one on kind of lessons learned, and just look for these videos. We'll link them below because I want you to have a lot of information before you start the process. This video is a little bit different. I'm sharing some lessons that I've learned, some assumptions that I used to make as a provider. I've learned so much helping people over 15 years. I'm not the same doctor that I was even 5 years ago. And especially when it comes to helping people in a same-sex couple build their families. And when I am seeing patients that have 2 uteruses and 4 ovaries, there were assumptions that I used to make. And I want you to be aware of these lessons that I've learned, whether you are a practitioner helping patients or you are the people who are planning to start your family and you go to a provider and some of these assumptions are made. I want you to be open and advocate for your care and realize that it is not out of malice, but maybe out of lessons that need to be learned. So let's go through these assumptions. Number 1, never assume that both partners want to get pregnant. So when I first started seeing same-sex female couples, I was so excited because I was like, oh my gosh, we've got 2 uteruses and 4 ovaries, and we just have so many options, and we can do testing on both and kind of like figure out, the fastest way to start their family. And, just kind of thinking about it more like parts and sort of optimizing success. When you have a hetero couple or someone with a uterus and someone with sperm, your options are limited. And so when you've got 2 people in front of you with uteruses and all you need is sperm to help with the equation, I just sort of used to think about it differently. Now, one of the first questions I ask is, what are your goals? You cannot assume that somebody who has a uterus wants to get pregnant. And that is just so important. People with uteruses don't always want to conceive. They don't always identify as being a woman or feel motherly in any way. And so it's really important to ask that question of patients. And if you're a patient, think about what is important for you before you go for that first visit and share what your goals are. I very often will offer testing for both partners to gather information. But if someone's really certain that they want reciprocal IVF and one partner is going to be donating the eggs and one partner is going to be carrying the pregnancy, then I don't always do a uterine cavity evaluation on the person who's planning to do the stimulation cycle and will retrieve eggs. I offer it, but I really tailor it. And we kind of go through options as we go. Sometimes we get surprises. Sometimes the person who wants to conceive or wants to use the eggs, we find out they have diminished ovarian reserve and they're very poor candidates for IVF. That doesn't mean that they don't try or don't, shut down that option, but it's important to know what the patients want, tailor the testing to it. And if you are the people trying to start your family, to really advocate and kind of know before you even start that first visit what your goals are. Assumption number 2, assuming that if the couple sitting in front of me wants to have more than one child, that they necessarily want to use the same sperm donor. It was an assumption of mine. And when I'm counseling people, often talking about how much sperm to buy from the sperm bank or how much to freeze if it's a known donor, et cetera, I'm sort of thinking about the long-term goals and maybe how many children the couple wants. And when you're thinking about vials of sperm, you have the option, even in a donor sperm bank, of buying more vials than you think you'll need. even keeping them and storing them at the sperm bank. And if you have completed your family, they'll often buy them back. But what's really frustrating is if someone has the assumption that that sperm is always going to be available, if they don't purchase it or they don't store it, then somebody else can purchase that sperm and you could come back for baby number 2 or number 3, and there could be no vials left. And so I just used to counsel patients and really just sort of assume that they really wanted to complete their whole family with the same genetic sperm. And that's absolutely not the case. And so again, I ask much more open questions. But if you are the couple that are looking to build your family using donor sperm, these are questions that you should ask the sperm bank. Talk to your doctor about how many vials you think it might take to be successful, and just think through those options. Number 3, I should never assume that somebody wants to start with the most simple and low-tech treatment. So it'd be very easy for me to assume that somebody wants to start their treatment cycles with donor sperm IUI, intrauterine insemination, because it's low tech, it's low cost, and it's a common option to choose. But I shouldn't assume that. I should ask the patients what their goals are. Again, there's an option of reciprocal IVF. Maybe one of the partners really wants a genetic link to the child, but does not want to get pregnant. And so that person might go through IVF, will retrieve eggs, fertilize the eggs with donor sperm, and when the embryo is ready, transfer it to the other partner that does want to get pregnant. This is reciprocal IVF, and both partners are sharing in this pregnancy journey. One is providing the egg and the other is providing the uterus and getting pregnant. And so I just never start off assuming. I spend a lot of time in the beginning really asking what the patient's goals are. And again, if this is you and you're thinking about your options, it's important to have those discussions before you show up at the clinic, because that person that you're talking to might just not bring up reciprocal IVF because they just had no idea that that might be your goal. Number 4, another assumption is to not assume that people are fertile. So, when you're coming to the clinic and you're a same-sex couple and you're planning to use donor sperm, it's easy to assume, well, I'm not infertile. The only reason I'm not pregnant is because I don't have sperm. But anybody could have blocked fallopian tubes or ovulation issues or uterine fibroids, which don't always cause fertility issues. But, it's just important not to assume. And so on the doctor side and on the patient side, it's important to talk about, hey, these are these fertility checkups. And yes, we could proceed and just do a insemination with donor sperm, very low tech, very inexpensive. But if it's not successful, and then we find out after 6 IUIs that actually the fallopian tubes were blocked the whole time, we would have wasted a lot of time and a lot of resources. So I talk to my patients about fertility testing once we know what the goals are. And sometimes we might try a few IUIs, intrauterine inseminations, before doing the HSG or the hysterosalpingogram that makes sure the fallopian tubes are open. Got a great video on that particular procedure. So check that out if you're thinking about doing an HSG. But it's expensive if it's not covered, of course, and it can be crampy. And so it's a discussion, but it's never a dogmatic, like, oh, you're so low risk for having tubal disease, you don't need an HSG. I discuss it with patients and it's a mutual decision. And number 5, another big assumption is to not assume that the patient sitting in front of me are necessarily comfortable being there. There, unfortunately, is a history, and it still can happen today, where same-sex couples feel discriminated against, feel, not well taken care of, even services denied to them at fertility clinics. That is not the case at my clinic, Pacific Northwest Fertility here in Seattle. I feel like the majority of fertility clinics are very opening to helping build all types of families, but that can be an issue. And so it's important to do research on the clinic before you go and make sure that you are going to feel welcome and that you're going to get queer, competent care, and that important language is used and assumptions aren't made. But for me as the provider, one of the first things that I do to talk to the couples is just say, hey, I've helped so many couples conceive their family. in very similar ways. I'm not going to make any assumptions about what your goals are or who's going to get pregnant or which eggs we're going to use. We're going to not assume, anything. And I just want you to know you're in a safe place. We take care of a lot of same-sex couples, and we're going to take really good care of you. Let's recap. What are the 5 assumptions you should not make when you are helping same-sex female couples build their family? Number 1, you should not assume that you know who wants to get pregnant and who doesn't. Number 2, you should not assume that the couple wants to use the same sperm donor in every pregnancy. Number 3, you should not assume that the couple wants to start off with the most low-tech and low-cost option. All options should be presented. Number 4, you should not assume that the people in front of you or the patient should not assume that there's not a fertility issue just because they've never tried to conceive, and all testing options should be reviewed. And number 5, you should not assume that people are comfortable in the clinic. There's an unfortunate history of discrimination of same-sex couples in fertility clinics that for the majority of cases is not present. It's certainly not present at my clinic, Pacific Northwest Fertility here in Seattle, but you should reassure people in front of you. And if you are the patients going to a new clinic, do your research and make sure that you are going to be welcomed with open arms to help you on your family building journey. I hope this video was helpful. Like this video if you learned something, comment with questions that you have, subscribe to this channel, and stick around for more learning.